Some of the things I heard during that discussion was kind of a wish list for research, right? So if research was structured so that it provided solutions instead of just the questions, so that it was packaged and communicated in a way that we could use it. We could kind of take it off the shelf and say, okay, now I know what to do. If it was actionable and translatable, and if it was contextual, so that it was done in a way and in a place where people who were going to use it could see that it related to their particular context, their state, their healthcare organization. And I think one of the things I heard Tom say also was if we were part of the research, if actually as a policymaker we were involved, and that certainly has been true in the CQIs, so that we knew that whatever solution they came up with, or whether it worked or it didn't work, we know that it relates to our particular setting. So, I think now as we move to the panel for the funders, and we have each of our distinguished guests will introduce themselves, but just very briefly, David Atkins from the VA, Karen Davis from Commonwealth, and David Fukuzawa from Kresge. We will want to hear from the funders about what can funders do to help structure research and research funding in a way that maybe we can get to those products that are more actionable, more translatable, more contextual, that provide the solutions and not just the questions. So, to start off with, if each of you could introduce yourselves briefly and maybe talk a little bit about the goal of each of your funding organizations with respect to having an impact on policy and practice, and maybe what specific areas, if there are specific areas, that you hope that the research that you fund will impact. And David, we can start with you.
So I'll talk a little bit from my experience, not just at the VA, but previous to that, working in HHS. And the common thread, I guess, to my career has been the joining point between evidence and practice and policy. And so over that time, I've tried to avoid getting too cynical about the role of evidence in Washington. And I think that one thing that's important to remember is that funders want to be successful too. So we are interested in showing an impact in the same way that you, as researchers, want to show an impact of your work, or those of you who are policymakers want to show that your policies are accomplishing things. So I talk about the sort of Vidal-Sassoon, if you don't look good, we don't look good. And so the question for us is, one, how do we train our researchers to think about what will make their work have an impact? And then the second question is, what do we need to think about in terms of our funding mechanisms to make it easier for them to do that? So when I came to the VA from AHRQ, the Health Services branch of HHS, I sort of thought, well, now this will be much easier because the researchers work, get the paycheck from the same agency that pays the clinicians and that pays the central office staff. And what I was surprised to find is that divide is just as real within the VA as it is out in the private sector. And the reason is that people have different incentives depending on where they sit and what it defines their career advancement. And so if you're a researcher in the VA, your incentives look pretty much like if you're a researcher in the university side. And many of our researchers we benefit from the fact that they walk both sides of that. And so their incentives are to get funding, to get publications, to get promoted. Whereas the advantage and challenge working for the VA is we are a mission-driven organization, and we have a board which likes 535 elected representatives who like to hold us accountable and like to ask very painful questions about how are we making the lives of veterans better. So I'll just close with my first sort of comment, is that I think researchers too often think about a push model. All right, I find a answer to a question, or I find a problem, and how can I push that message out? And I think we need to move to recognizing where there's pull. And so what are the things that your audience of policymakers want information on? Where's their pull in the system, and how can you give them information that has a natural, so that you're not pushing upstream against something, but you actually have a natural receptor point in that. And what that involves is building relationships so you understand about the problems that are at the top of their inbox, and not trying to argue that that thing that's at the bottom of their inbox ought to be moved up higher. The caution in that message is that that we struggle with is we don't want to be overly reactive. So the problem that's at the top of the inbox 5 years from now may not be at the top of the inbox, and we don't only want to be studying the crisis of the moment. And so sometimes, and it's important for researchers also to realize that they're want to get ahead of the curve, and so it's research that can often drive what's at the top of the inbox. So it's balancing that tension between feeling free to study things that may not be the problem of the moment. If we look at the patient safety agenda, a lot of the work about patient safety was sitting there for a long time, not going anywhere until the IOM came out with their report about patient safety. And so Lucian Leape's work at Harvard, that had been there a long time. And sometimes you just have to hit that moment where it suddenly takes hold and gets people's attention. But at the same time, if you're not aware of what your audience is caring about and the constraints on their decision making, you can end up in a lot of dead-end alleys by studying something that just doesn't have a point of connection.
Great, thank you, Carrie.
I guess my first message is that every funder is unique, so I know that's going to be discouraging because you can understand the Commonwealth Fund and the way we operate it. It still doesn't do you any good with Kresge or Kellogg or Robert Wood Johnson, so we're all different. But I thought I might touch on 4 things. First of all, mission. The mission of the Commonwealth Fund is to promote a high-performance health system, especially for those who are vulnerable by reason of being low income, uninsured, racial ethnic minorities, young children, frail elders. So the first message for researchers is don't try to get in our door unless what you're working on is germane to that central mission, because we actually have a guideline from the board about how fast we have to turn people down, and ideas that are outside of our mission we have to turn down within a week. It is important to understand what a foundation funds and where's the right place to go, and there are sources like the foundation at Center, et cetera, that you can find that out. Second, value-added foundation. I spent the first part of my career in academia, so when I went to Commonwealth Fund, I was fantasizing about this great job I was going to be having. That was 20 years ago. And it's an elegant, historic house, and I thought they sit around, they have tea, they go through grant proposals. Because I had in mind the government model of peer-reviewed, investigator-initiated research along the NIH Agency for Healthcare Research and Quality model. But that's not the way the Commonwealth Fund works. We are a value-added foundation. First of all, we're a mixed operating and grant-making foundation. So a minimum of 60% of our funding is extramural, but the rest can be intramural. Plus program officers that work in partnership with grantees. So when we say value-added, unlike government, we view the work of the program officer is to make the research better. and to work hand in hand with the grantee to refine the project to make sure that it will have a maximum impact. And then as it comes out, particularly to find communication opportunities for grantees to get that research findings in front of relevant audiences. But the real key is asking the right question, and for us as a foundation, because of our cycle of funding and research, we want to fund research that will answer questions policymakers have 18 months from now. So we need to know what Congress will be asking for 18 months from now, fund the research, find the best person to do that research often, and have the results ready when Congress wants the answer. So you think, how on earth can you know that? Well, it's very obvious that in the spring of 2013, the Balanced Budget Act of 2013 will be number one on Congress's mind. And that's been obvious for at least a year and a half, for 2 years. So we have a commission report going, our Commission on a High Performance Health System, on which Dr. David Scher sits, to have answers for Congress ready by the spring of 2013. So we find that window, that wonderful window when something has to happen and the parties have to get together to make something happen and try to have research to go. People aren't aware that we also, in fact, the majority of our research by board direction goes to help private sector leaders answer questions on their mind. And it can be Tom Zimmer at the Blues of Michigan. It can be the head of the University of Michigan Health System. So what questions are they going to have on their mind? And I was privileged for a couple of years to attend sessions between Group Health Cooperative in Seattle's management and their internal research center and talk about exactly the questions we're talking about now. And so the management wanted to design a patient-centered medical home, wanted to know what the optimal panel size per primary care physician was and what the team mix was. And the researchers wanted to know the epidemiology of obesity using the medical claims data within the system, or the medical records information within the system. So the management actually didn't want answers in 18 months. They wanted answers this month. Anyway, having at least that vehicle to communicate what management would find useful and what researchers were interested in is useful. So value-added foundation, our program officers have an annual program plan. They lay out what they've accomplished in the last year, what they think the questions are 18 months, 2 years down the road, and what they would like to fund this year to kind of move toward that. Third, our strategy. Our strategy is, I will say 5 things. Informing public policy that contributes to a high-performance health system. So we did set up in 2005, when we viewed Washington being in gridlock and not much happening, a commission on a high-performance health system with the simple charge of find solutions that simultaneously lead to better access, improved quality, and lower costs. So tell us the answer to that within a year and a half, 2 years. And they did, in fact, do that. And it was part of a report called The Path to a High-Performance Health System that was, in fact, the basis of the Affordable Care Act and the starting point for Congress on that legislation. We also have a program on health insurance, a program on payment and delivery system reform. So those are the ways in which we try to inform public policy. Often a lot of that work is simulation modeling work. If you do this, then it will have this effect on access, quality, and cost. The second strategy is to identify, assess, and help spread delivery system innovation and improvement. So we have programs on quality and efficiency improvement, patient-centered coordinated care, vulnerable populations, frail elders. I view my role at this high level as the identification. I call myself Johnny Appleseed. So I say, oh, would you believe what Henry Ford is doing on patient safety? Oh, would you believe what Geisinger's doing on a patient-centered medical home? And I go around the country and I give talks and I talk about, oh, the blues of Michigan, oh, the blues of Massachusetts, and get people excited about what we see as the most innovative things out there. And as an organization, we pride ourselves on being old, since we're not as big as Robert Wood Johnson. We got started in 1918, and in 1925, our annual report said the role of the Commonwealth Fund is to distinguish the promising from the proven. So we both find these examples of excellence, but we also try to really fund the evaluation assessment research, which will find out, in fact, whether what looks good on the surface is. A third area for us is tracking and assessing health system performance, and we fund a lot of surveys. That tends to be our intramural work, the analysis of those surveys, but we make those survey databases available to people. But we obviously do it because we don't think the big government surveys kind of are fast enough or get the kinds of information that policy officials need. We also fund a lot of work on scorecards, and I'll talk a lot about that at noon. On comparative data, our board met this week, and they kept saying comparative actionable data. It needs to even drill down further so that an individual hospital knows what they can do. And we do have a website called Why Not the Best that has individual hospital performance, but it's one thing even to have those aggregate measures on quality or cost and to drill down from that. Another strategy is learning from cross-national experience. We've had an international component since 1925, but we revamped it to really try to help U.S. Policy officials and healthcare leaders learn. And I go around, oh, you wouldn't believe the Danish health information system and what they do there. Oh, you wouldn't believe the Netherlands off-hours care initiative. So try to get people excited about not is the Canadian system or the UK system better than the US system, but is the off-hours care system in the Netherlands better than what we do on nights and weekends here. So the international learning that's possible. And then finally, effective communication, and we've talked a lot about that here. We're very clear about who our target audiences are. And it's actually not the general public. Our audience are policy officials, and it tends to be federal since we don't have the resources to be involved at the state level, although occasionally we are involved there. And healthcare leaders, private sector leaders in a position to make changes in the system, particularly the payment and delivery system that can lead. So having identified those audiences, I just feel like the electronic age came along just at the right time for us. So a decade ago, we shifted from printing reports, which also costs a lot of money, storage costs of warehouses and mailing, to total electronic distribution. And we have 45,000 people on our listserv who get our email alerts about reports. And as was mentioned in the earlier panel, for our grantees that publish in journals, we do these 2-page in the literature summaries that have a very fixed format, so you go very quickly. Got a little section on the methodology, research design, but you very quickly to the findings and then the implications of that. What do you do given that you know that? But we also obviously put out press releases for our journalist audience, policy briefs, blogs, but short. And we do what we call audience surveys, which are web surveys of these 45,000 people. And we've done them repeatedly, and they used to tolerate 20-page reports and then 10-page reports and then 2-page reports. So it was clear that a lot of people want their information very, very boiled down, and so we work on that. But we are also finding webinars are starting to work with our audiences. We do a lot of convening of meetings, fund over 100 meetings a year. And what we do with our grantees is work not only to help them figure out how to communicate more clearly the great kernels that are in their research, but how to present it to members of Congress and congressional staff. We fund every year a meeting of members of Congress who are involved with health issues. We've always gotten bipartisan attention, out of the spotlight, out of the need to posture, amazingly cordial interactions. I think it's the spouses who are present that helps with that. But anyway, or the kids at the swimming pool. So it is a very collegial environment, but a good interaction. So we take our we plan a 2.5-day program. We take our grantees into those sessions. Members stay after every session, after every meal, kind of pumping these people for information. And then we get follow-ups. One of the chief Republicans wanted one of our presenters from Camden, New Jersey, to come and brief the entire Republican Health Caucus on what he said about hot spotting and how they target on high-cost patients. We do get information to journalists, but we also, when the press call, as they do, I've certainly in the height of health reform doing interviews, 1 to 2 interviews every day with press. So we have cultivated good relationships with press, know they can rely on the information, but we give them the names of grantees that they can call. So that's another way that those come in.
So, Karen, just because
Yeah.
sorry, you
lots
guys
more
do,
and a lot more
well,
opportunities
I want to
to
give
say
you
these
the
things.
exactly the opportunity to answer some very specific questions about Commonwealth and impact, and also give just a chance first for David to tell us about Kresge, and then I really do want to get to some of these very specific questions, and I know you have great examples about impact, very specific impact of research that you funded. So just a couple minutes, David, about Kresge and the areas you hope to impact.
Well, I will just echo Karen's opening statement that there are a gazillion foundations, and they're all very different. But I thought today, in the other remarks I'll have, I'll try to represent as best I can the foundations that we consider our peers in the field, which include RWJ, Robert Wood Johnson, Kellogg, Kaiser Permanente, and the California Endowment. But before I do that, I want to sort of say something about Commonwealth, because I think you have sitting here before you a relatively small foundation endowment-wise, but whose influence, through the harnessing of the intellectual capital, through research and otherwise, far outweighs the influence of an even much bigger foundation like Robert Wood Johnson. And with all due respect to them, I mean, they've been an enormous influence, but Commonwealth has been uncommonly significant, I think, in terms of shaping the discourse in this country around at least healthcare reform. So I just want to give that kudo to you guys. So, I mean, for those of you who aren't familiar with them, I think you should just be aware of that. I do want to say, in sort of that the Kresge Foundation is somewhat new to this game, even though we've been around for nearly a century, and many of you might be familiar with Kresge just because we're responsible for a good part of the infrastructure of this university, insofar as we've done a lot of bricks and mortar through most of our history. But starting about 5 or 6 years ago, we've really begun sort of a historic transformation of the work we do, and we fund actually across 6 areas, of which health is only one. But within the health area, let me be clear about our bias in this. Just because the whole foundation is really oriented towards improving low-income opportunity and especially helping to revitalize urban places, that our focus is on vulnerable populations. And from that perspective, we think that the greatest gain to be had is going to be on the upstream factor side. That is to address, I think I can use this term in this audience, social determinants of health. I can use that. Communications people always tell us we shouldn't use that terminology. And we're focusing particularly on the impact of housing, of transportation, built environment, and food. Just but we actually look across a broad range of things. And we only touch upon the kind of downstream, the healthcare part, insofar as we touch upon community health centers and the primary care safety net. But even with the healthcare system, what we're looking at is using the frame of the triple aim of trying to think very, very hard about what does it mean to improve population health. And as a shameless kind of advertisement for something that we're doing, we commissioned this work through the Institute for Alternative Futures, and it's called Community Health Centers Leveraging the Social Determinants of Health. So community health centers, as you know, is a movement going back 40, 50 years, and they actually started by trying to improve the conditions in the community for health, including Jack Geiger's famous prescription for food, which actually is being replicated here in Washtenaw County Public Health Department. But what we found out through this study is that there has never been a study of exactly the impacts of this work, even though there have been some profound things like the elimination of hookworm in the South in a specific community. Never documented, never researched. So there's a huge gap in research there. So that's kind of our little niche within this area.
Thank you. So within that context, and I think we have funders here with really kind of three different perspectives. One funder really focused on a healthcare system and how do you fund research that impacts a healthcare system, the largest integrated healthcare system in the nation. One that's really looking at improving healthcare delivery throughout the nation in different ways, and one focused on vulnerable populations. What I'd like you to think about is, perhaps share with us examples, and I'm going to limit you to no more than 2 examples that you have funded in your organization that you feel have had an impact in the areas that you're trying to influence. But very specifically think about what did the researchers do right to get to that impact? What were the characteristics of that research that made that possible? And what did you as a funder do to help kind of move the research toward impact? So, again, 1 or 2 examples would be great for the audience. David.
So I'll just use one example because it sort of shows the cycle. So back in when Ken Kaiser was the Undersecretary of Health for the VA back in the late 90s, he instituted a really major transformation of the VA at a time when the VA health system wasn't really known for high quality care, and that really embodied a number of changes. One was a move towards primary care, from a model of sort of inpatient care to a primary care model. And that was driven in part by research done in the VA about how to deliver healthcare more effectively in primary care. The second was a commitment to evidence-based practice. The third was a move towards regionalized organization of networks. And fourth was the use of performance measurement to drive accountability, and the fifth was an investment in electronic health record. So all of those things were informed to varying degrees by work done by researchers within the VA. Researchers were part of developing the electronic health record. The VA was sort of ahead of the curve on that. There was some research on the effect of performance measurement. So those things were all critical to what was really a profound transformation of the VA that's really, I think, been responsible over the last decade in changing the perception of VA as a high-performing health system. But I'll take just one example of performance measurement as an area where performance measurement was critical to moving performance over the last decade. But we've now gotten to a point where we're starting to recognize that performance measures have upsides and downsides, and that those trade-offs are different when you're starting at an area of low performance than when you've gotten up to a point of relatively good performance. And so Eve and her colleagues at the university and at the VA have been really critical in studying and writing about the potential downsides of performance measurement and an overly prescriptive approach to black or white performance measures, where you get rewarded if your patients with diabetes have a hemoglobin A1C below a certain level, and you get no credit at all if they're 0.1 above that measure. And so that research, first to say, yes, these were good. Now they might be incentivizing the wrong care. They might be going against our goals of patient-centered care, because they look at a physiologic measure and not everything else about a patient. They may be especially problematic in the VA, where we have patients who are elderly with lots of problems. And so they may be incentivizing polypharmacy when you have to meet a performance measure about blood pressure, about diabetes, about hypertension, and you're adding more and more medications to patients who have underlying depression. And they may be causing harm as a result of that, and they're driving providers crazy. And so the research first said, well, maybe we need to start to back off, and then in echoing the comments we heard in the previous panel, they said, okay, is there a solution there? So can we think about what's our next generation of performance measures which would reward providers for doing the right thing? And doing the right thing means making progress. So rewarding the provider for getting a patient's blood pressure from 180 down to 143, rather than punishing them for not getting below 140. And rewarding them for saying, gee, in this elderly patient who has a life-limiting condition, it's probably not appropriate for them to get colon cancer screening, which has a 10-year payoff. And so how would we design performance measures that would, I think Eve's term has been actionable performance measures, that would reward clinicians for doing the right thing, put the accountability for what the provider has the control of, not punishing them for taking care of patients who have multiple problems, and where the provider's done the right thing, but because the patient is homeless, because the patient has severe depression, maybe they aren't adhering to all the things that the provider has done. And so to try to recalibrate what was in general a real important, and I don't mean to knock performance measurement, and I think Dave Gifford said, sometimes you just have to get out there and start measuring. You improve the data, and then you have to recalibrate now how we're going to measure and how we're going to act and how we're going to create incentives. And so I think we're still in the middle of that journey of what we sort of think about as second generation performance measurement. The VA had a very kind of top-down incentive connection of performance measures to incentives for the network directors. You were going to get paid. Your bonus was going to depend on whether your facilities met these targets and performance measures. And now they've started to realize some of the limitations of that, so they're really going to more nuanced approach to how we incentivize our managers and our leaders to promote performance, but not to take an overly, what can be a very blunt instrument. So the hope is that this work will evolve into a next generation that will both equip providers to do the right thing, reward them for doing the right thing, equip and reward managers for looking at their system to promote more of doing the right thing, and not get into the trap of a checkbox where clinicians are feeling forced to do something that they don't really think is the right thing just so they can check that box and hope that their bonus or whatever incentives they have will follow.
So I just want to say I didn't feed that example to David, but thank you. But if you have 2 seconds to comment on, do you feel that there was a role of the funding organization, of the researchers, to help move that to something that's practical or actionable and just?
Well, I mean, so one of the things that it made it possible is the program I run, which is part of our health service research, which is really aimed at implementation. And so it's much more, and we actually get our money from healthcare dollars rather than from research dollars. So we've always had a very clear goal to, we better show our value or they're going to find better ways to use that money. And so we've, as a result of that, our focus when projects come to us is, okay, is this going to be something that our partners on the healthcare side will understand and value? The ideas may come from the researchers, the ideas may come from our partners. And then I think because of that, we've, over the 10-year span of this program, have really formed much tighter partnerships between the researchers and their healthcare partners. So basically, Eve, people know Eve, or people know the researchers in our program. When they want to reach out for a question, the people who run our performance measurement program know the researchers who can help them solve the problem. And when our researchers come to them saying, hey, we've got some ideas of how you can improve it, those are not strangers. And I think the morning panel emphasized that they're not going to reach out to somebody who's just because they're an author on a New England Journal, but if there's someone who they have a relationship with and trust that they understand each other. We did some work within our program where actually we had anthropologists, study, because these really are two foreign cultures, at the beginning, and they live in different biospheres and they have different customs and traits. But over time, those relationships, everybody understands the constraints and incentives in a way that they can work more effectively. So I think our challenge is how do we use our funding mechanisms to build those relationships and sustain those relationships so they're not just kind of short-term things.
Great. Karen, 1 or 2 examples of research that made an impact and how you think the researchers and the funding organization helped make that happen.
Well, I'll jump at the chance to do 2. One focused on public policy, one on private sector action. The one on public policy was research on the Massachusetts health reforms by Sharon Long at the Urban Institute, and we co-funded that with the Robert Wood Johnson Foundation and the Blues of Massachusetts, which is one of the ways that we take our small dollars, leverage our professional staff, and take credit for the impact of the research. But our staff did talk among the 3 funders about the way to go about evaluating the Massachusetts health reforms that were enacted in April of 2006. And as academics, and I still consider myself an academic at heart, we can think of far-ranging, comprehensive evaluation methods: quantitative, qualitative, medical record information, claims information, survey information. I said, what you get the most bang for the buck for are just population surveys. They're quick, they're relatively inexpensive. You get the answers to the questions you want to answer because you designed this survey. So let's do a baseline survey before this starts rolling out, and then let's do annual surveys. And then we identified Sharon Long because Urban Institute had done some modeling work for Massachusetts leading to their reforms. And just that simple baseline versus 1 year after enactment, 2 years after enactment, proved very useful, finding things like access to care improved. There was a lot of, all these people going to be covered, there aren't enough doctors, care will deteriorate. It turns out that if you become insured, it's easier to get an office visit than if you're uninsured, and access actually improved. So despite all the rhetoric about there aren't enough doctors to handle all these people, it showed that care got better. And then the other was that the employers will drop coverage if the state is going to cover people. And in fact, we showed that because there was the individual mandate and workers had to have coverage, employers wanted to help them find an affordable way to get coverage through group insurance instead of individual insurance. And in fact, the 11% increase in employer coverage. So that has won the Impact Award from Academy Health, the Professional Association of Health Services Researchers. And it's influenced what we do because we now have baseline surveys on the Affordable Care Act, longitudinal rolling out, 3 different ones really, one on low-income families, contrasted with high-income families, so basically everybody, but oversampling low income, and then a survey of young adults and a survey of older adults, 50 to 64. So we will be using what we did in Massachusetts with the Affordable
That's a
Care
great
Act.
example.
The second one, Professor Michael Chernew spent time here at the University of Michigan, now at Harvard, is on our commission on a high-performance health system. Actually, I was so impressed with the work he did here with Mark and others that we got him on the commission, and my goal was to make him a national figure of an economist doing relevant research. So early in his career, identified talent we wanted to give visibility to. But anyway, we funded Michael and Rob Mechanic to do an evaluation of the Blues of Massachusetts, what's called the Alternative Quality Contract. It is not capitation. It's not capitation. It's not capitation. It's a fixed dollar per person per enrollee. A payment to provider organizations, but it's not capitation because it's based on prior experience, and they also get bonuses for hitting quality targets and have a multi-year commitment. Anyway, Michael and Rob Mechanic's research published in the New England Journal of Medicine and captured by our, in the literature 2-pager, showed that it saved 1.9% in costs, and it did so by shifting where patients got their hospital and specialist care from more expensive hospitals to less expensive hospitals. So it not only showed the effect, but what of the many things that they did seemed to be the big determinant of the savings. The CEO of the Blues of Massachusetts said he got a phone call. One of his best days was a phone call from the more expensive hospital saying, if we cut rates, can we be the referral hospital again? And he said, we've got a deal. So that's an example of something we fund, the kind of impact it has and what we're looking for.
Thank you. That's great examples. David, 1 or 2, and then we'll open it up to questions.
Yeah. Before I give some very quick examples, I just want to say something about that I didn't say before about what funders do, and vis-a-vis this whole research policy connection. First of all, as it's been pretty clear from the other panel and this panel, this isn't a linear process, right? It's probably more chaotic than linear. So funders are actually concerned about the whole, what I call, ecosystem of change. So, and you see a good example of the 2 other panelists talking about, the kinds of things that get done. But, classically, foundations are not only interested in research, and there's some that are focused on that, but they're interested also in the researchers. So, you have things like RWJ's fellows programs, scholars programs, et cetera, that support especially emerging scholars, just to do some of the basic research. But you also have a lot of work around translation and supporting the organizations like CHART that support translation, high quality translation, and also support let's say the broader public education, advocacy, public awareness building, et cetera. So quick examples. We participated with Hewlett in a major RAND study out in California around air quality's impact on hospital admissions. So RAND did their typical kind of in-depth and relatively conservative study, which showed there were billions of dollars that were lost because of bad air days in California. But what the plan was not just to leave it at that, but to really build an echo chamber. That is to develop a broad coalition of the leading advocacy groups, and as Dave Gifford pointed out, everybody knows what they're going to say, but also to educate the medical community, to build that as another sounding board for this particular issue. That is to say that in order to move to public policy, they really wanted to use, through professional communications advice and consultation, to get this sort of broader echo in the broader public, not only from the people that were always concerned about it, but from the medical community, to say this is an important concern. That was a way to sort of amplify the impact of a study that, was relatively hard to understand unless you could, sort of burrow down and see what the numbers were. But I mean, that is really an analog for the kinds of things that foundations have done all the time. And I'll give you an example on obesity. I mean, Robert Wood Johnson has funded centers for sort of some of the research, but they've also funded a lot of work on the ground in terms of demonstration projects, program evaluation, publications around that, communications around that, building the constituency around this, developing even a whole social media campaign on this. One of our partners, Kaiser Permanente, is major underwriter of the new HBO series, which is coming out on obesity, which really relies on the whole base of evidence that has been built up around this particular crisis, which is not simply a medical one, but one which is a public health one, through bad nutrition, lack of activity, et cetera, the built environment. And supporting the key advocacy organizations inside the Beltway that work specifically on how this impacts things like the Farm Bill and the Transportation Bill, which most people in this audience might not think of as important public health or medical pieces of legislation, but they are. Mm-hmm. In the long run, if we can get people to move more or eat better or have access to better food in areas like Detroit, that in the long run will have bigger health impacts than a few more $1 billion in the healthcare system, our point of view. But I mean, I think that reflects how funders are thinking about how we begin to change things, built upon the evidence certainly, but realizing that this process is a lot more complex, going all the way up to how you deal with legislators at all different levels.
Great example. So we want to be able to take a few questions from the audience, questions for our funders. There's a question over here. Steve.
Stephen Bernstein, professor of internal medicine here at the university. The title of our symposium is Can We Speak the Same Language? And one of the things your panel and the previous panel clearly demonstrated is the need to improve communication between researchers and policymakers and funders. We've heard about different mechanisms that could be done to do that. So one example is training individual researchers or policymakers, so something that Mary Ann's unit talked about doing a fellowship for. Robert Wood Johnson brings in former clinical scholars, health policy fellows for 2-day symposiums on doing this. The Ontario Health Research Institute, done by Jonathan Lomas, brings in about 20 policymakers and researchers a year to try to train them to talk to each other. A second mechanism, though, is setting up communication programs. So Karen Davis talked about how Commonwealth has a program where they do these policy briefs. I'm sure the researchers aren't the one who write these 1-page, 2-page briefs. My question for your panel is to think of yourselves as an advisory board now for our Institute for Health Policy and Innovation. And how do we fund this type of effort? Do we want to send our researchers out for this type of communication training? Or is it better for our institute to set up a communications office? Our School of Public Health has, a PR program. Our medical school has a PR program, but those aren't really communication offices, the way I'm hearing you talk about your programs. And then more importantly, how do we fund it? Being, hands on the ground, how do we keep this going? Would your organizations approve an increase in our indirect cost rate to fund this type of program, or would you allow funding for a direct cost for this type of communication strategy?
Great question.
So I think it's important to train researchers in how to do the communication, because they are going to be important faces and advocates. So rather than, and I don't think an institute, now certainly in the VA has as much pull as an individual. Now that might be different for a Commonwealth, which has sort of a brand, a recognizable brand. So I don't think you can just centralize it all in a communications shop, and that there should be a mechanism. I think another part of it, I just want to get back to the point I made earlier. It's not just about pushing information and communication, that we do need some other mechanism for engaging researchers to think about how to frame their question in a way that will resonate with their audience. And that process has to start earlier when the studies are designed. So I think if we only focus on the communication aspect, once the research is completed, we've only tackled half of the problem. And so I would encourage the Institute to think about what are the mechanisms they can support that will bring policymakers in to say, here are the questions we have. And that's what we've tried to do with this new funding mechanism. And our first example was, homelessness is a priority for the VA. We brought the person who's the head of the homelessness program together with researchers and to just exchange, here are the problems I'm trying to wrestle with. Researchers said, here are the kinds of things we've been studying. And they actually shaped those projects from the beginning. And in terms of funding it, I think that as a funder, we're certainly happy to think about ways that we can support those mechanisms. And in these new grants, we actually funded meetings as part of that support to bring those people together at the table at the beginning. And then in our funding decisions, we look for evidence of the fingerprints of the customer, of the stakeholder, on that proposal, and a proposal that looks like it was developed by researchers and then got a signature from the stakeholder after the fact doesn't do very well. If there's evidence of how the stakeholder shaped that proposal, those do better.
Okay.
Well, I'll be shameless. We again are cheap, so we try to buy at the margins. So we pick grantees that already know how to do this, but they know how to do this because they've spent time in policy positions. So they've taken a fellowship, an RWJ Health Policy Fellowship. So we fund a David Blumenthal, who was a health policy fellow, or a Jean Lambrou, who worked in the Clinton administration. Then they go back to academia. We fund their research because we know they know the right questions and how to do the research and communicate it in a way. But aside from actually spending time in government, serving on an Institute of Medicine committee, as Mark and I are serving, you just keep learning what's going on in Washington and what are they thinking and what do they want to know, or being on a Congressional Budget Office committee or a CMS committee or MedPAC, and we help our grantees get on these bodies and on these committees. So it's continuing to learn what the issues are, what the questions are, how to communicate it. In terms of your question, I can't see that we would ever fund a communications office at the Institute, so it's got to be part of your infrastructure. If you do it, I think there's certainly a value of having an in-house resource that helps train the researchers on how to do both written and oral communication. We wouldn't build it into our indirect cost rate, but what we will do if a grantee asks for it is fund into their grant a dissemination component that pays some of their time to present at conferences or hearings, et cetera. You know, I spent time in academia, was at Hopkins, I feel like you had to work an 80-hour week because 40 hours was pro bono. So, testifying 10 times a year before congressional committees, nobody funded that, So a lot of this good work is simply unfunded, but we will build it into the research project funding.
I would say that there's sort of in principle, there are foundations that would support communications. I think more and more we all realize that, the message and the framing are so critical. Having said that, I agree with Karen that there's kind of a branding issue here, because we're like any other shopper. Who are we going to call? Who's going to have kind of the instant cred? Who can talk to policymakers and that sort of a thing, for things that we're concerned about, and that's where it helped. Where the language gap might be in that, the researchers feel intensely passionate about the things that they're focused on, but they're often not the things that funders or policymakers are concerned about. So that's where there has to be some kind of engagement at that level to sort of see what funders are in fact important or can consider important. So but in principle, I think you will find a spread of funders who would be interested precisely because they're interested in getting messages out, especially if it supports their agenda.
So that was a great question. In the interest of time, I think we're going to have to conclude this panel in the interest of your break. But I think that this conversation actually will be continued when the researchers speak because of the interaction between the researchers and the funders, and also during and after the lunch.